Live.
Okay. Assalamu alaikum and good evening, respected physicians. Welcome you all in today's program. This is 60th program organized by ECG Study Group, and today our speaker is respected Dr. Azizul Haq sir. As usual, before going on to the lecture, I request Professor Abdul Wahid Chaudhary sir to introduce Azizul Haq sir among our audience, and then we'll proceed on the lecture.
Assalamu alaikum and good evening, everybody. Today, we are going to have some interesting case presentation, ECG presentation from Dr. Azizul Haq. Dr. Azizul Haq is currently serving as senior physician, faculty and consultant cardiologist in Division of Cardiology at Emory University at Atlanta. He's involved in postgraduate training of intern residents and cardiology fellows at Emory University. He did his MD from Moscow First Medical Institute in 1986, then finished his PhD in cardiovascular research in 1992. Later, postdoctoral fellowship in University of Iowa. He completed the residency in internal medicine from Medical College of Georgia and cardiology fellowship from University of Louisville. He's specialized in nuclear cardiology, and this is his academic background, but consider the other things that I'm going to speak about. Dr. Aziz, our beloved Aziz Bhai, is involved in multiple philanthropic projects. He started the telemedicine clinic in one of the largest slums in Dhaka in 2014, and he saw patients once a week until 2019 on behalf of Distressed Children and Infants International. Dr. Haq developed a cloud-based electronic medical record system with video conferencing and designed to treat the unprivileged people around the world that is still active and graciously supported by the Salesforce.com Foundation. And another aspect we should know about, recently he was the principal author and editor of a collection of all the guidelines regarding the accuracy elevation MI. And that booklet is available in Bangladesh by the courtesy of Healthcare Limited, Healthcare Pharma. So anybody is interested can get that booklet, and that's very useful, I would say. I'm also fortunately involved in that, as well as Rafiq sir and Hafiz Bhai. And today, Dr. Azizul Haq, our Aziz Bhai, is going to present some interesting ECGs. We are eagerly awaiting for that. Aziz Bhai, the audience is yours.
Thank you very much, and good morning in US and good evening in Bangladesh, and for giving me the opportunity to talk here. Basically, I'll discuss some cases. Sometimes reputation is very important. This is mainly designed to our trainee physicians, to our fellows. To be attentive to those cases, because you will see those again and again, and so that we don't miss those things, and also try to understand certain things, that how important clinical presentation is. That's the focus of my talk today. I'm not an interventional cardiologist clinician. I'm mainly clinician. My focus is mainly nuclear cardiology. That's my specialization. But always listen to the patient. That's very important in making diagnosis and treatment. Without further delay, I'm going to go with the talk. I'm going to share the screen. Let's see. Just 1 second, let's see. Just 1 second, I'm going to. Which screen came? Say, let's see. This is the blank screen though. Yeah, I found it now. All right, and now we see the screen, right?
Yes, please.
Okay. All right, I'll go ahead and start, and I do not have any disclosure. let's go ahead with the first case. These are real cases. Actually, the patient herself was an ER physician in different hospital, and her husband works as a neurologist in Emory. Okay, 65 years old lady, presented with severe chest pain initially that woke her up from sleep, about 8/10 in intensity, left-sided pain, lasted 10-15 minutes, which prompted her to come to the hospital. She's normally very physically active, does exercise 4 days a week, no problem before. But recently they went on vacation and do the hiking and felt some chest tightness and pressure for a few minutes when she was hiking about 4 days ago. And apparently it stopped, and that she didn't bother with that, okay? When she came to the ER, she was given sublingual nitroglycerin. Her pain kind of improved, but not totally gone, okay? And her past medical history, she has hypertension, cholesterol, prediabetes. And 2 years ago, she had a coronary calcium score, and her coronary calcium score was 138. I don't know the distribution of that, but that time she had an exercise nuclear stress test by one of our colleague physician, because she's an Emory patient. 2 years ago, it was negative for ischemia. Her patient has her medications like aspirin, lisinopril, cholesterol medication. She has prediabetes, but kind of diet control, not on any medication. Blood pressure is fairly controlled, 138/75. On arrival, pulse was 90. First set of troponin was normal. And I'd like to show the ECG. And patient was seen in the ED. This ECG was evaluated by the primary care physician, emergency room physician. And definitely, that's the diagnosis they put in there. You see that at 10:23 a.m. Please look at the ECG. I'd like to somebody from our participants in the trainee physicians comment on the ECG. Anybody can please jump on that.
Hand raise করলে তোমাদেরকে প্যানেলাইজ করে দিবে, তাহলে কথা বলতে পারবে।
Anybody can do that, because I like to be interactive, so that we can discuss.
Any volunteer participant?
And be bold.
Abu Naim Mahmood Hassan.
Yes,
he raised his hands. He is allowed to talk now.
Yes, please.
Sir Abu Naim Mahmood Hassan, you can speak.
Okay.
Kindly, would you please?
Abu Naim, please describe the ECG. Abu Naim.
নাইমের কানেকশনের প্রবলেম হচ্ছে, ওটা হয়ে আছে, স্টিল পিকচার হয়ে আছে।
Probably, sir.
Abu Naim, are you available to talk? All right. I think there's some issues. Okay, anybody else? And you can see that, initially when patient comes to the emergency room physician quickly tries them whether the patient has a STEMI or non-STEMI. That's basically what they put in, okay? All right. Okay, so I think, anybody else, or should we go further?
I think you go ahead.
Yeah. Okay, let me go ahead on that. And the reason is very important that patients, because you know that anybody comes to the emergency room with acute chest pain, you have to define whether it's acute coronary syndrome or not. And in the acute coronary syndrome, they go to different category, like one is STEMI elevation category, and other is either non-ST elevation or unstable angina in that category. Because in the STEMI, you diagnose, they go quick pathway, the STEMI pathway. That's very important, this type of patients, to recognize that. The reason is, look at this ECG. It's not like very unusual, but look at that V1, V2 lead. There's some subtle ST depression there, okay? And it's not like too tall R wave that you normally see, but there's some concern about that. But the patient feels better, but you know, she still has some short tightness in the chest, but pain is gone, main pain is gone after nitro. And the ER physician disposed the patient to observation unit. So she went to the observation unit and sitting there. And finally, they decided to call cardiology consultation. My fellow saw the patient, okay? And I said, okay, and he called me. I said, okay, I'm going to come down and see the patient myself. I always try to go with the fellow myself and examine the patient, talk to the patient, and find out what's going on so that we can teach at the same time. And what we decided, the way the patient presented is still not very comfortable. I did the EKG again. It looked normal, but the question, not normal, the similar EKG, excuse me, it's not normal, but there's a sort of change. We decided to do a posterior ECG on this patient. Actually, initial discussion was right now what to do with this patient. So we repeat in 4 hours the troponin, whether do pharmacological stress test. Actually, the patient sent to observation unit to do a stress test first. That was the initial discussion the ER physician had. And or whether go for left heart catheterization directly or repeat ECG or echocardiogram. Definitely, everything could be done, but what's the best right option right now at this point? So when you go there, you know, always remember that if you have any doubt, any cases, and the patient is still not totally normal, patient is a physician herself, the patient's telling me, I still feel some tightness, not totally gone, but I feel much better, okay? And then the question right now, we repeated the posterior ECG. We just decided to do posterior ECG. I asked the fellow, just let's bring the machine, let's hook her up and do the posterior ECG. And let's look at that. This is the posterior leads that will relate to V7, V8, and V9. You see, there are some subtle ST elevation there. Because in posterior leads, you need only 0.5 millimeter ST elevation. You don't need much. So the reason I'm showing that ECG, always when you have doubt and borderline ECG, and there's question about V1, V2, V3 leads, there's some changes there, you're not sure, always try to do a posterior ECG if you don't see anything else otherwise. Because in certain posterior MI, definitely if you have a ST elevation 1 in a VL or inferior leads, you know that it is STEMI going on. But there's nothing else in other leads. V2, V3, those leads, subtle change in ST depression. And patient, you know that there's some discomfort going on and there's some clinical scenario there, you should not ignore it, do the posterior ECG. And we call it STEMI then, and the patient definitely went to STEMI category right away. Because look at that, what's the timing, yes? Yeah.
Can I interrupt for a second?
Yes,
so
please.
that ECG, if the patient was totally asymptomatic and came for leg pain, would you have done anything?
If it's totally asymptomatic, no. Question right now.
So there's a specific reason I'm asking. We have been emphasizing this thing for the last few sessions, that the clinical scenario, the reason Ajit and your team did all this, you did not ignore that slight discomfort. And that is key, right?
That is the key.
This is the important part, that you talk to the patient, you don't just look at the EKG, and then also asking patient question, are you having chest pain, is a wrong thing to do. You have to ask patient, is there any funny feeling in the chest? Are you totally normal? And that's when they tell you that, yes, I am not feeling pain, but really my chest is not right. Thank you.
And it's an important question, because reason is, when I go with the fellow, my fellow always says, Dr. Hawk, when you go inside, you always find something new. The reason is you need to learn in medicine how to talk with the patient. Because your goal, before you go to the room, you have to have some predetermined thinking that what question you're going to ask and what answer you would like to get it from the patient.
Adit,
Sometimes
can I interject something?
Yes, please.
আমি যেমন আমার ইয়েতে বলি যে বুকে ব্যথার কথা কখনো জিজ্ঞেস করবা না, তুমি বলবা বুকে কি চাপ লাগে বা অস্বস্তি লাগে বা খারাপ লাগে, এই তিনটা শব্দ আমি ইউজ করতে বলি। বাংলায় ঠিক হচ্ছে ফানি ফিলিং না বলে যে এইভাবে বলি। তুমি বুকে ব্যথা বলে রুগীরা কিন্তু বলে ব্যথা না, বলে দিবে ব্যথা না।
That is correct. And interesting enough, because look at that, I'm going to show you why I'm putting this ECG or certain things here today. Let's look at that, how the cath showed. You went immediately to the cath. Definitely we did aspirin, heparin and everything, Plavix that it needed. But let's see, and you see that here. Okay, this is like there's some flow, but it's probably already recanalized a little bit. But initially, when initial presentation, probably a STEMI, but now there's like opened up a little bit. But look at that. The question right now, if you miss the patient, the reason I'm putting this case, look at that, how, and we'll open up and I'll see how big the left sarc is, how big it is. It is wrapped around to the apex. Wrap around to the apex. Okay, let's go to the next picture. Okay, yeah, this is probably the same one. Okay, and the RCA, and if you look at that, it's just some borderline disease there, but not bad. Okay. But look at the LV-gram, though it was hand injection, the whole apex is down. Apex anterolateral area is down. There's significant LV dysfunction on these patients. And he sat down 2.5 hours, almost more than 2 hours, without anything that we could do, because we could have done that. If I would have seen the ECG in the emergency room, I'd have taken to the cath lab right then. Okay. If with the posterior ECG, look at that, the apex is down and anteroapical area is down. Okay. So patient basically underwent angioplasty. Okay. And a huge left sarc, basically wrapping around the apical area. And let's look at that, how the echocardiogram looked like on this patient. I'd like to show you some view. You see that whole apex is down and how much LV dysfunction the patient happened. If we did not pick up these patients, so already damaged a significant amount, and looks like we followed up that patient, still EF is down, but definitely about 10-15% better than we had it before. You see the whole apex is down. If I would have seen the ECG, sorry, just the echocardiogram, I would have thought probably the LAD is down because there's the apical area, right? Mostly apical, posterior-apical and a little bit anteroapical area. But the reason the whole apex is down because left sarc is very huge, is wrapped around to the LAD. All right, let's go to the next level. Let's see. All right, the reason why I'm putting this case because posterior MI STEMI is often misdiagnosed, often missed. The reason being, normally you don't see that standard ST elevation in the ECG that we normally see if it is isolated posterior MI, and also those MIs even retrospectively dismissed. Even the patient already heard that we didn't know because they do not produce Q waves that we see in other MIs like inferior Q waves, anterior Q waves. Because posterior MI do not produce Q waves. So even retrospectively, even you miss that. Okay, like in a study, like they studied about 1,200 patients with acute coronary syndrome, and with isolated ST depression, no other leads problem. Okay, only V1 to V4, and interestingly enough, 25% of them out of 1,200, that is 300 patients, had occluded arteries, and 50% of them were just circumflex, just with some minor ST depression in V1 to V4. That means 150 of them had occluded posterior circumflex artery. And another important point I'd like to make, because not only we miss that, even they have symptoms or something, the data we have here in this study, they presented 1,200 cases, and we found out that the time to reperfusion, average time is 29 hours, because the patient sit there, next day they do the heart cath. If it came on Friday, they probably do the heart cath on Monday, okay, if they missed it, okay. And it definitely increased the mortality, and you see the morbidity. Patient is in heart failure, that's in our own patient, despite that she's a physician, okay. So the importance is that when there's suspicion, please do posterior ECG. The reason being, if you do the posterior ECG and you see the ST elevation, that's 0.5 millimeter, that all you need, they can quickly divert the patient to STEMI criteria. That means their management is quick and all the STEMI protocol follows through that. Otherwise, the patient sitting there, like with chest pain, maybe just non-STEMI or something, and may get heart cath later on, okay? So there's another one study in 1999, it was published with just circumflex artery occlusion, okay? Only 1/3 had other ST elevation in inferior leads or lateral leads, they qualified the STEMI criteria. And interesting enough, of them, 50%, if they did posterior leads on those patients, 50% of them had 1 millimeter ST elevation on posterior leads, and 25% had ST elevation only present in posterior leads. That means 1/4, if you did not do posterior leads, you would have missed on those patients, 1/4. Just when you have doubt, please try to make sure that you're extra cautious, extra vigilant, listen to the patient. Any symptoms, if you feel uncomfortable, do the posterior ECG. And if you look at that, in 2001 study published, that just they looked at the left circumflex artery occlusion. And what they found, if they have, like, if they did the posterior ECG on those patients, if you take cutoff point 1 millimeter, then you can catch, that would be TCH, not CAT, TCH, catch. It could catch 53% of them, okay? But if you take cutoff point 0.5 millimeter ST elevation, you get 94% of them that would qualify STEMI. And those data came into the guidelines that we have in the European or ACC guidelines, that posterior ECG cutoff point in V6, V7, V8, V9, any of those 2 leads minimum, 0.5 millimeter. That's all you need for posterior STEMI, because then they would qualify for the STEMI criteria. So I already mentioned that, okay? So I'm giving some example of the, posterior MI. We know that this is like classic posterior MI, like tall R wave, ST depression, upright T wave, and like 1 in AVL, there's questionable slight ST elevation. So you know there's probably posterior MI. And you do the posterior ECG, you see some ST elevation here, V8, V9, little bit ST elevation, you can see that here, okay? I'll show some few ECG examples. Like here, this is a classic one, another one, like R wave tall, ST depression, upright T wave. But look at that, no other leads have issues there, no other leads, only isolated V2 to V4 probably leads ST depression. But when you look at that, do the posterior ECG, you see that ST elevation here, ST elevation here. Okay, so the reason I'm putting that, don't miss that, those posterior STEMI that you might qualify acute intervention. Like another case here, there's another subtle case, okay? Very minor ST changes here, not much in other leads, okay? But patient has symptoms, chest pain, okay? And do the posterior ECG, same, minor change in V1, V2, but look at that, V7, V8, V9, there's V8 and V9 ST elevation there. Okay, let's see. Another one, like this one, we definitely would have missed if the patient doesn't have any symptoms, okay? Look at that, tall R wave, but very normal looking. We would have called probably early transition. That's probably all we would have called, okay? If the patient has symptoms, if you see this ECG, nothing else anywhere, look at that, the posterior ECG, what it shows. The same one, we could have missed it. ST elevation here, V8 and V9. V8 and V9 ST elevation. That will qualify STEMI criteria. Anyway, there's another one I'll show you. This is very benign looking ECG, okay? Little bit RSR pattern, nothing else anywhere. Patient having symptoms, chest pain, all right? Be suspicious, do a posterior ECG on this patient, and you see ST elevation here, ST elevation here. So there, and it's very simple to do. Just take the 3 leads like V1, V2, V3, keep it there. V4, V5, 6, just put it there in the back. Okay, the scapula would be below this scapula would be V8, left parasternal area, spinal area would be V9, and posterior axillary line would be V7. You don't have to print out the ECG, just click there, look at the monitor. If you don't see it, you're okay. Just takes a few seconds to do it. Anyway, take home message from this case that standard way definitely is a tall R wave, ST depression you see, unless there's other reason like right bundle branch block, WPW or RVH there. Always be suspicious with the patient having posterior involvement. Okay, and definitely there are some other findings that you have that's in classic form you'll be able to see. But if any doubt, do a serial ECG to see if any changes you see, even 1 in AVL or V5, V6 or inferior leads. If any doubt, or otherwise just do a posterior ECG. If nothing wrong, then you're okay. At least you can follow the non-STEMI criteria on that patient. Anyway, that's the first case. Let's talk about another case that I had difficulty with my patient, this one, but I'd like to share with you and see what we can discuss. This is the 51 years old female. She has hypertension, mild obesity, not that big. Her major problem that she walks a little bit, she gets short of breath. Little bit, she doesn't have to do much. Even doesn't have to go to the mailbox. Just a little bit fast walk, she gets short of breath. Okay, that has been going. She used to do exercise before, no problem. This is happening last 6 months. Okay, and the patient, just with that problem, she went to the emergency room because she cannot handle that. And they didn't find anything wrong. ECG looked normal, baseline ECG. They did an echocardiogram on these patients, like 55–60% normal function, grade 1 diastolic dysfunction a little bit. She has blood pressure, most likely that's the cause, okay? And she actually underwent a pharmacologic cardiac PET nuclear stress test, okay? That gives you coronary perfusion and also gives you coronary calcium score is 0, and stress test was normal, okay? And then they sent her to get evaluated by the pulmonary physician, lung doctor. Lung doctor did a pulmonary function test, it's normal, chest x-ray was normal. Then the lung doctor sent back to the cardiologist because patient is still having short of breath, okay? So my concern right now, what to do with this patient, okay? So we always see this type of difficulty when you see those patients in our office. So the question right now, she already had a stress test a few months ago, okay? And it was normal, coronary calcium is normal, right? But still, she clearly tells you when she walks a little bit, she gets short of breath, okay? So what we'd like to do, can you do a poll at least? Let's see what our audience says. Rivu?
Sure, sir. I'm starting the poll.
Yeah.
Uh,
Whether you need to do a left heart catheterization on this patient to better understand, whether they need to do exercise stress echo on this patient, whether they need to get right heart catheterization to evaluate the pulmonary pressure, whether they need to do CTA chest, whether undiagnosed COVID or something she had some pulmonary fibrosis or something going on, or just observe the patient.
Sir, should we go for 30 seconds?
That will be fine, yeah.
for today we only have 4 options, sir.
That's fine. That's fine. Just eliminate the last one because definitely we have to do something for this patient.
Here is the result.
All right. I think pretty good audience. Okay, at least we'll see what we discuss, what we have done, and I see the results. You remember that, and we'll discuss that. Okay. So I think it's a very good option that half of our audience chose 50%. That let's do exercise stress echo or something like that, some sort of stress testing that you can observe yourself, because she had a pharmacologic stress testing before that she didn't walk, because that's the wrong thing to do begin with, because patient could walk on a treadmill. They should have put her on a treadmill that day, because her symptoms is exertional, right? When she walks, she gets out of breath. But they ignored that in the hospital. They just did quickly. They wanted to get the patient out from the hospital. They did a pharmacologic stress test, normal, go out and follow up as an outpatient. Not the right thing to do, because since the patient is already in the hospital, they should have evaluated the patient properly. I mean, okay. So let's see. So what I did, initially, I think the audience chose the right thing because the question was put that way. I did not think myself also doing a stress echo that time. I decided to put her on a treadmill, but also in our office. And also I wanted to check her oxygen level. Let's see whether the oxygen level drops or anything with exercise, whether what's causing her short of breath. Okay. This is her baseline ECG. Looks okay. I don't see anything unusual. And she started walking. Her baseline oxygen level is fine. Blood pressure is okay. 142 is not bad, slightly on the high side. But as you know that she takes 10 milligrams of lisinopril for blood pressure. Should have better control a little bit, but she's probably a little bit excited, anxious, pressure is a little bit high. But I decided to put her on a treadmill. And she's walking, and look at that. When the heart rate is around 100 over 6, she wants to left bundle branch block. Okay, no chest pain. And I felt comfortable to let her walk further because we know that her coronary calcium score is 0. Her recent pharmacologic Lexis scan stress test was negative. So we decided to continue. Let's see how far she could go and how much short of breath she feels, how much symptomatic she is. And where she went up to 130 heart rate, that's close to 80% probably. And then she had to stop. She could not go further. Okay. And what we decided, her oxygen level is fine, no an adequate rise in blood pressure. So it's really blood pressure didn't drop either too much, because that was another concern, this dropping blood pressure. So I decided to, we had an echo machine side by. Initially, I think the audience chose exercise stress echo. That probably would have been the right thing to do to begin with, but I didn't think that way initially. I just decided to treadmill first. But since she was in the room with the echo and our echo taker was there, I asked her to put the probe right away on the chest to see how the LV function looks like. Okay. Yes. Any questions and discussion?
Azul, before going to clinical discussion, can I ask about the ECG?
Yes.
That's stress ECG, please. Before.
Yes. Any comment? Let's the beginning. Okay. Just resting.
No, during the stress. Next.
Okay. Okay. This is the almost as much as she could do. She could not do further.
This one. Sir, actually, Rofik sir, what is the rhythm, sir?
This is during stress test, so I think it's probably sinus.
And you can see the P wave here.
Yeah,
P wave.
sinus with rate dependent left bundle branch block.
Okay.
But the question is whether it's VT. It is not VT because if you look at lead V2 and V3, the initial R wave is very narrow. So that's consistent with left bundle branch block.
And if you look carefully here, you can see P wave here, P wave here, P wave here. So it's sinus tag, okay? And the question right now, and we see that, and it slowly comes down, it's still in left bundle branch block, and the heart rate is like 93, and then when heart rate 84, she goes to flips back to normal QRS. Okay, but she was very short of breath. She was at 75, 80% that the maximum she could go. She's very short of breath. So I had to stop. No chest pain. There's no drop in oxygen level. And we decided to put the probe on the chest quickly because to see if there's any issues there. Okay. And I had previous echo, and I'd like to side by side, I'd like to put it together if I could do that. That's the baseline that from the previous echo. Looks like normal, you know, the contracting well, all the segments, okay. And here we see some bouncing of this side, okay. I see the apical wall, apico-lateral walls coming up, but the lateral wall kind of lagging behind a little bit, okay. I'm trying to see if simultaneously we can play. How quickly it comes to the lateral wall, it's a little bit lagging behind, okay. Definitely we'll discuss that all together, this issue. Let's see. I'm not sure. Let's see how good. Now, you know, we decided later on analyze that area, okay? And we put some color software analysis there. And let's see if I can analyze that. Here, you see that the bright red is contracting well, and this kind of a little bit lagging, okay? And this is the longitudinal analysis we did, longitudinal strain. And let me explain a little bit briefly for our fellows. Look at these lines, because here the color-coded lines. This is the yellow line. This is the like green. This is like more green. This is the magenta, blue, and the red. Okay, and look at that. These are the representation how the contraction going on of each segment like that. Okay, as you see, like these segments. They're contracting well. All the segments that's color coded here, from here to here to here, they're contracting not bad. They're contracting well. This is the aortic valve closure. Okay, there's a contraction going on. But look at these two segments, this segment and this segment. This segment is kind of still relaxing when the other segments are already contracting. And the lateral one, this one, is still relaxing way up to the middle of the contraction. And we see the other segments already finished contraction. So we are wasting this part. They're not participating when the patient LV is contracting. That's going to waste because of dysynchrony of the ventricle, wasting of the cardiac output that's happening, and that's probably causing her. That's possible, this for discussion because I'm still puzzled what happened to the patient, but I'm giving you some findings and I'll talk to you, and EP is involved here. So I'd like to get your input also. So the picture I'm showing here, because in the software analysis, it clearly shows here, there's delay, there's relaxation going on up to this part, this segment, lateral segments and these segments. While the other segments, these all are contracting by this time. This is called longitudinal strain, okay? And we are wasting this part due to this ventricular systole we call dysynchrony. The lateral part is still relaxing rather than bulging in. Let's see. So what happened then? We decided to put the patient, okay, if you want to discuss something and I'll go further or I can continue. So we decided to put him on some metoprolol, 25 milligram, because we thought that, oh, maybe let's control the heart rate, doesn't go higher, so she doesn't go to left bundle branch block. But she comes back after a few days, she feels dizzy, and she came to the office. Heart rate is 42, sinus brady, okay? Like we checked heart rate initially 42, but ECG shows around 40, but it narrow QRS, okay? And we decided to discontinue the metoprolol, okay? And then the question right now with this situation, first thing that we did, okay, let's go ahead and do the heart catheterization to find out why she's short of breath, okay? But no significant coronary artery disease. I'm just letting you know. At that point, we decided to talk our EP people, but let's discuss that before I go further, what they did. All right.
Did you have an eye chart, Kat, Aziz bhai?
No, I did not, actually, honestly speaking. I did not, okay? I should have done that.
Symptoms were profoundly shortness of breath.
That is actually, I should have done that, but with the echocardiogram, we didn't see much. Actually, indirectly, tricuspid regurgitation or anything, not much their problem at all.
No,
So
I
we
think
decided-
the stress echo, we want to do the tricuspid post after the peak exercise to see.
Yes,
did
that
you
is-
see anything in the peak exercise? Because she got profoundly, two things happened. Sinus tachycardia, most likely rate-related left bundle, but profoundly short of breath. So the RVSP went up with the stress test.
Yes,
yeah.
Yeah, that's correct. And actually, she, at this point, I sent the patient to EP for further evaluation. They did a stress echo there, and they actually looked at the peak that Dr. Hassan just mentioned. They looked at the peak exercise. Patient is profoundly dysynchronous, okay, and short of breath, and we didn't see any pulmonary hypertension then or regurgitation then. That's the reason, probably, right? And I didn't do the right heart cath, but they didn't recommend that either. I'm just letting you know that time, okay? So that's where you are. And then what they did.
Did you do the pro-BNP?
No, I did not. I did not.
That would have been helpful.
Yes. Yeah, I understand your point. Absolutely. The question right now, this patient definitely had diastolic dysfunction,
Yes.
but questioning Dr. Chaudhry Hassan's point, where there's a question when the patient goes to left bundle branch block, where this diastolic dysfunction is more profound, or this pulmonary pressure, secondary pressure goes up. We should have checked it though, but we did not. So that's another good point. Okay, but
to support like Adut's point, we did a study of diastolic dysfunction. We did the baseline BNP, and then we did the exercise-induced BNP. And with the particularly those with baseline LVH, if you let them do exercise, their BNP goes higher with the LVH and diastolic dysfunction. So that tells you something, right? That patients with normal LV thickness and some normal diastolic function, very unusual to see diastolic dysfunction, but it's very common with LVH to see the diastolic dysfunction with LVH. Particularly, I don't know, I joined late. Is this a hypertensive hypertrophic cardiomyopathy?
No, he doesn't have those features. Hypertension and not much alveolar thickness. Okay.
Yeah, that's why I was like wondering, because
Okay,
your strain echo showed longitudinal strain.
Yes.
There are some changes in the longitudinal strain. So
yeah,
there
there's
is some kind of diastolic dysfunction, most likely.
Yes.
No, she does have grade 1 diastolic dysfunction by mitral inflow pattern. She does have grade 1 diastolic dysfunction. Okay, she does. Okay. Then at this point, we decided to send the patient to EP, and the EP decided to do an EP study on her because there's a question about, they wanted to study.
Please mute the other. Dr. Jilu, please mute your microphone, please. Thank you.
All right. So EP did the study. I'm going to talk about that. Before you do so, for our fellows, I'll like to give a short brief what the understanding of that. Okay, like his bundle tracing, so that they understand the reading of that, the procedure they did. In the his bundle tracing, what we do, we go through the groin to the femoral vein.
Ajit, can I interrupt you for a second?
Yes.
What are the indication for EP study? Because for every test, there should be a clinical indication. What was that indication to do an EP study on this patient?
That I have to ask the REP guy, because reason the EP shows I sent to the EP because of this intermittent left bundle branch block, and patient is symptomatic. Okay, so I wanted for.
I understand that part,
yeah,
but my question would be: I'm putting multiple catheters in somebody's heart.
Yes, I agree.
Forget about multiple catheters, but even if I want to do an echo, there should be a pre-procedure diagnosis. Why I am doing that test? Why did they do an EP study?
I don't know. They decided to do it. I asked them to get evaluated. They went there. They decided to do EP study. Okay. I have to ask him the question, our EP doctor. But anyway, they did so that to understand that. I'm just, for the fellows, I'm just letting them know exactly what the meanings of the readings are.
So in general, I have a quick comment. If I am the referring physician, I need to be convinced that why the consultant is doing a procedure in my patient. And I want everybody to make sure that if you are referring a patient, I have the obligation to satisfy you that this is the reason I'm doing a procedure. Because I am a consultant, I want to do something. I want to explore. I want to go to moon. I want to see the moon. That's not a reason for doing a procedure. I need to convince my referring physician that there is a clear indication for something to be done and what we are trying to achieve here. Because there is no conduction abnormality that they are going to fix, right? This is clearly rate-related left bundle. The diastolic dysfunction, what EP procedure will tell us? LV systolic function is preserved. I don't see any reason for doing an EP study. There is no reason for doing EP study.
Hafiz bhai, can I take something?
Yeah.
I think the heart rate becomes slow and patient has syncope and left bundle. That's why they think that
there is no syncope. There is shortness of breath.
Shortness of breath. Not syncope, but bradycardia with a small dose of beta blocker.
Sinus bradycardia and following metoprolol. I'm not convinced, but I will be convinced if you give me a good reason.
Okay. Mohsin, I understand Mohsin's point that EP physician may have said that there is dizziness, let's find out.
Yes, that was
okay. But that could have been easily investigated by a 2-week heart monitoring rather than an invasive procedure.
That is correct, but that was the reason they gave me. Okay, that was the reason they gave me.
So they actually, this is the funny part about medicine business is that I can always write something as an indication and do something. But the question is that Hafiz is pointing out that is it necessary? I don't personally feel at all that this was necessary, but anyway, this was done. Let's move on.
Yeah.
Okay, so, but Aziz bhai, let me tell you something. I tell the fellows, if you are doing a stress test looking for coronary disease in a 20-year-old, give me a good reason. And I agree. Let me give you the analogy. I tell them that say that you are looking for anomalous coronary. Don't say atherosclerotic coronary disease. Similarly here, if you are the EP guy, and by all means, I cannot blame the EP guy because he is not here or she is not here. So there may be, they're suspecting infiltrative cardiomyopathy and significant conduction disease. I don't know, but I would say make up something else, but not just the LVH and common variety hypertensive LVH and diastolic dysfunction and do EP. That's not good enough. But if this is a sarcoid or amyloid and you're looking for significant conduction disease, maybe there is a justification. I don't know. I'm just trying to see the other side.
Now, you're absolutely right. Actually, the main justification they gave, the patient's feeling dizzy with the beta blocker and is heart rate on the low side, and also those intermittent bundle branch block. I think that's the rationale they gave. But that's the reason actually I'm putting this case here, because still I don't have good understanding the way it proceeded further. You understand? Myself, I don't have a good understanding how it was proceeded. That's a the discussion I'm putting it on. All right. So briefly, when you put the catheter in, there's the high right atrium. We get the atrial activity that coincides with the P wave. Then when you put this catheter in the His bundle area, we get the A wave. That's the atrial activity. This is the bundle of His H, and there's a V activity. That's on the ventricle. When the catheter is the ventricular area here, we get the ventricular activity. And also one thing I'd like to make sure for our fellows and trainees that AH part is the important part to remember, because that part could be varied by sympathetic activity, parasympathetic activity, exercise. that part you can manipulate. But this part is fairly, you cannot change much in the HV area. Anyway, what they decide and they did, I'm going to show you the results. I've just tried to put it there, copied that. And what they found, they tried to pace this they initially start pacing that her, and when they pace her at 500 milliseconds, that's about heart rate of 120. 60 heart rate is 1000 milliseconds cycle length. They try to pace her at 500 milliseconds, and she had left bundle aberration. Okay, but to begin with, her HV was slightly prolonged. Normal is 35 to 50. In that range is 65. I'm not sure, Dr. Rafiq Ahmed and Atharvai, you can confirm that, but that's my understanding. HV is slightly prolonged as baseline, okay, but not as bad. But and she was profoundly symptomatic when she went to a bundle branch block. They could reproduce that, okay. So, but there's no total infranodal block, but definitely HV was prolonged, okay. And what they did on the basis of her abnormal HV intervals and her symptomatic late bundle branch block, they proceeded with cardiac resynchronization pacemaker, okay? So they put a bi-V pacemaker on her. And interestingly enough, but the thing is that she's doing fine now. She can exercise and she doesn't have any symptoms. That's the dilemma I have, okay? Yeah. And we checked her pacemaker recently, and she definitely LV pacing 98.5%. She's currently 75 milligram of metoprolol extended release, okay? And CRT device pacing is the same, would be LV pacing, because she's basically doing the most LV pacing to synchronize that. So that's how we are. So I'm just opening it for discussion.
Okay.
But she's clinically doing okay, better.
Yeah. Okay, Ajay.
Yes.
So this is the few things. First of all, let's make an assumption that this patient is doing well. Question was, pre-procedure, what was the 6-minute walk distance? We don't have data. Is she totally symptom-free now? And this EP study plus implantation of bi-V violates. If this patient died on the table, from the complication of this physician would have lost his license. I can guarantee you that. I don't know if Hafiz has any comment on that.
And that's the reason I put this case here, because I was not very satisfied the way it proceeded either, you understand? Because I didn't have explanation why they went ahead. But I talked to the EP guy. So he said patient is symptomatic and patient has HV interval prolonged. And that's the reason they put the bi-V pacemaker with most LV pacing. That's the discussion they gave us.
So, okay, HV interval, the indication for IC pacemaker in a patient with prolonged HV. If somebody is totally asymptomatic, HV interval more than 100 milliseconds, especially with bundle branch block, you can put a pacemaker in, because those are high likelihood of developing heart block. Second indication is HV between 70 and 100. If somebody has fascicular block and history of syncope, or even without syncope, then you can justify, especially with fascicular block, means right bundle, left bundle, or any kind of fascicular block. And these are the indications. So this will be exactly like somebody having chest pain, has a 55% RCA lesion.
I understand it.
Hafiz or Wadud putting a stent in that patient.
No, we will not do it.
Yes, there is a stenosis, patient is symptomatic, and I put a device in. I mean, this is beyond me. I mean, I cannot even imagine it, that I will even, first of all, I would not have even put a single catheter in this patient because there is no clinical indication for putting a, secondly, I would have loved to look at the HV interval measurement. I'm not being critical of this physician, but a person who studies a patient like this, you look at the tracing, how he made the HV interval. So you need to pull up this HV interval tracings and ask them to send you the tracing with the markers and measure them and send it to somebody else to see if the HV is trustworthy in this patient. I doubt very much. I mean, I'm not being critical of a physician, but somebody who does EP study on this patient, his age interval measurement is 65. I'll take it with a grain of salt.
Rafiq bhai, I think as a proof of concept, this is a very good provocative thing that we just observed. Because what is the bottom line on this patient? This is a patient with diastolic dysfunction and worsening of the diastolic dysfunction with left bundle
branch block
exertion. So with that in mind, the physician went after that idea that if we do synchronized pace with the exertion, that will be a good thing and symptomatically better. Does it follow any current guidelines? No.
That is correct.
And
No.
should I send my patient for this? No, because it may not be, cost effective, risk benefit, a lot of things. And one patient does not mean a lot, but to prove the proof of concept, this is actually very provocative.
And the reason
I'm
No.
touching on that point. Let's talk about so let's say this is a 52-year-old female versus an 85-year-old. There's a big difference. So let's say if I could prove that after putting beta blocker, her heart rate is 35, she doesn't have shortness of breath, but she is dizzy because of the heart rate, then I could have put an atrial pacemaker to keep the rate up.
she was dizzy, but didn't pass out. She was dizzy.
Yes,
I mentioned that.
I'm saying that like the way we do in certain situations, somebody with heart failure has benefited from carvedilol and heart rate has become 35 or 40. I can justify a dual chamber pacemaker in that patient or single chamber AI pacemaker. But I mean, it's an interesting case, and Hafiz put it very, Hafiz normally is a little bit less.
Reason is,
very nice way.
Rohit bhai, the reason is, I think this, our EP guy, he actually is specializing on dysynchrony a lot. He is doing a lot of research on ventricular dysynchrony. I have a feeling that he had in mind probably that point, whether if you can synchronize that ventricle, because if he goes to bathroom, if patient gets short of breath, the heart rate is like above 100. Or we prove that if the patient's heart rate is like 105, 106, goes to left bundle branch block, and she feels it. She immediately feels it. So I'm not sure that idea he had in mind, and though it's not in guidelines yet, the synchronization of the ventricle on exercise, that might have she had in mind, and definitely pathologically, a mechanistic point of view, it is helping the diastolic dysfunction. That's probably the improving her symptoms.
Aziz bhai, luciotropy is a problem in cardiology, luciotropy, but we have no drug for that, except we just heard that the emperor preserved, the SGLT inhibitors may be giving some help with the diastolic dysfunction. I don't know whether that might be a cheaper to try on this patient rather than going for the EP first. But certainly it is a very astute observation that she went into left bundle on exertion. And it all depends, 80-year-old, somebody, enjoying life, playing golf and doing a lot of things, it is maybe work, but average, it is a problem to take this as the standard of care at this point.
No, absolutely. And I still think it was off level, to my opinion. I discussed that with our EP guy, but he just told me, let's see how she does. But I know it's not right indication yet. I totally agree with you. Yes,
I did tell you.
I'm listening to you.
What I don't like about this, this EP evaluation, this is not an just electrical problem. So without defining, secondly, if this is not, it's not the question of label or off label. He made up an indication for EP study, and then he made up an indication to justify by V without clearly explaining why. So he said, I'm going to put a by V because the HV is 65. So whatever he is telling you verbally, in writing, he did not. You have to look at his note. Like sometimes I do it. I have used flecainide and metoprolol combination, which is a totally off level for POTS patient. And the patients have benefited. But in my note, I clearly mentioned my concept is it has anticholinergic action and beta blocker will keep the heart rate down and the patients may benefit. And actually some patients do benefit, but that's medicine. This is the invasive procedure. Yes, to put it politely, it's provocative, but he has, this can be done on a research protocol. As an exception, somebody can say, I have a concept of this and let me do this in some patients. But I don't think this should be even considered as a standard of care at all.
No, I understand. That's the reason I put this for discussion, because I had questioned myself and I was not very satisfied, but we're going to watch this patient in the future, but I saw the patients for follow-up. Yes, Dr.
Dr. Adit, if we are not giving any CRT that has been done, what would you have done in this patient? What medicine you would have preferred?
The medicine-wise, it would be difficult to do. I think if that's with dysfunction, you could do like spironolactone. I know the TopCat trial was kind of negative trial because of this Russian, Georgia, and those Eastern European. I think they did a lot of mistake there. But overall, the United States part, aldosterone antagonist was really, really positive in the treatment for that because she has hypertension. Okay, so we could probably switch that or add a low dose spironolactone for that. But another question, I would not have resolved that late bundle branch block, because when she walks, she goes to late bundle branch block.
And that's why I was thinking about.
So
we have used, as the beta blocker was inducing so much bradycardia and dizziness, could we have used a little dose of evaporative?
I just think about that. That's another concern. I was just thinking about that when you asked about these questions. That's possible. Okay, that's possible. Okay, but we haven't tried that, but that's a possible thought. Absolutely. Okay.
Aizbhai, may I make some comments here? I think this is very important because when you give the patient beta blocker is one of the powerful pharmacological intervention to prevent exercise-induced tachycardia, right?
Absolutely.
So when you give the beta blocker, did you see that the tachycardia response was less, or patient could not tolerate?
Patient could not tolerate because patient is feeling dizzy and heart rate. She has an Apple Watch. You know that they always monitor that heart rate. She's calling me every day.
48, 50 heart rate is okay. That may be a good thing. There is no need to panic. But another important thing I wanted to mention, and in your patient, maybe in future you need to think about this. One of the things is a significant number of diastolic dysfunction patient has what they call the cardiac amyloid. And when we are in the medical school, we used to believe that it's a rare disease. And it is rare, it's AL amyloid. But in the elderly, even in the TAVR patients, up to 12% of patients had transthyretin amyloid. Now, this is very, as you know, you're following this wild type of the V variant. In JACC, a couple of weeks ago, or maybe last week, there was an excellent review article on the cardiac amyloid and diastolic dysfunction. We are not diagnosing enough. So we are now doing pyrophosphate scan for those patients, and they have overt diastolic dysfunction on exertion. BNP goes high, and a significant number actually is not AL amyloid. So you can actually do the pyrophosphate scan, do the exclusion. Something like usual thing is neuropathic carpal tunnel, all these, but you need to be vigilant. So I'm just throwing this idea that in future, if you see that there is still some symptoms that she may have a SAM effect, like, the placebo effect with the pacemaker feeling better, but it may come back. You may consider to do the pyrophosphate scan for cardiac amyloid, like transthyretin, not the AL amyloid. Doesn't look like she has AL amyloid. Just a thought. And then of course you can try SGLT inhibitors, but I would go step by step with the cheaper version. But definitely this is a provocative kind of case, and bringing up some of the underlying issues.
And Dr. Hassan, it's a very important point you made about, because we are missing a lot of amyloid. The reason is we have transplant unit here, cardiac transplant and all these things, and LVAD that we put these patients. But we looked at that, and with the biopsy results, we are seeing that we missed a lot of amyloid before. So definitely in Emory, we are definitely, we are doing more and more pyrophosphate scans. And almost everybody gets on the echocardiogram this longitudinal strain to look at the apical sparing pattern. At least just some screening, we look at it. Yeah, we definitely upped that scale, and we are more vigilant about that nowadays. We missed a lot in the past.
So the another thing, the cherry red appearance on the strain is a classic.
Apical sparing. Yeah.
Your patient has regional. It is possible. So yeah.
I think, can I wrap it? I just want to make some wrap-up comment on this, if it is okay. I mean, this is an interesting case, and shortness of breath is a common but also difficult problem to assess sometimes. And a lot of times we have a tendency of ignoring the patients also. But so I think we have to pay meticulous attention to these patients, number one. Number two, one of the other factors is that how much is the patient, history taking is very, very important. You have to first determine what is the baseline status of this kind of patients. Are they exercising? And somebody who doesn't exercise one day wants to go up the stairs is a problem. Secondly, when we evaluate, we must write down the exercise ability baseline, excluding pulmonary problem. Second is then cardiac. And the cardiac, one of the things that even until 2 years ago, we did not pay much attention is amyloid. Amyloid, we are finding more and more amyloid. This is becoming a very big thing, that all those unexplained shortness of breath, a lot of them are coming up with amyloid. The other part, a lot of the patients with atrial fibrillation may have etiology, maybe amyloid. And then there is treatment coming up for this. So I think that is something that we need to keep in mind, that the new generation of doctors are going to deal with it. But the most important part is that we cannot ignore the patient. And the other part, Hafiz mentioned, if younger doctors did not, this patient felt better after a pacemaker. Please don't ignore placebo effect. Question is, you have to find out after 1 year. And the third issue, when we want to experiment with something, experiment with less invasive things, medicines. And of course, ivermectin in USA is we cannot, insurance company will not pay for it if there is no cardiomyopathy. But this is one thing to think about, to keep the heart rate down, and then to see if the patient exercised and the heart rate went up to 90, didn't develop left bundle, what are the symptom benefit? So those are the kind of things that we have to look at. Thank you.
Now, the very interesting discussion. Actually, this patient will follow, because I'm definitely more concerned about that. We'll see. I think I might go ahead and do a pyrophosphate scan on this patient myself. But initial echo longitudinal strain did not show apical sparing. So that part, or that's we kind of screening wise, we kind of excluded that. But in the future, if she has more problem, then we definitely need to proceed with that. I have some patients on ivermectin, Dr. Wadud mentioned, and I know it's very costly here, but actually there's very good medicine in certain situations. They're very effective, and patient tolerate very well. All right.
Thank you.
All right. I'm not sure. Is it 11:50?
I think it's 1.5 hours today.
Okay.
Please go on.
Go on. Okay, I have another case I can do. That's kind of repetition, one case, but make sure you don't miss it. Let's see. This 42 years old it happened to me as in the ED that day. A patient has been experiencing over the last 2 months some palpitation, okay, and runs few seconds, stops, okay. But this time it can continue, and she felt dizzy. She came to the hospital, right? Otherwise, no chest pain, tightness, other symptoms. She gets some mild short of breath when she goes uphill. Past medical history, no major medical history. She's fairly young, 42. She came to the ED. She was doing okay. And then the nurse was evaluating the patient. On the monitor, she went to certain rhythm, okay? We do an EKG. Blood pressure still okay. She's still awake with that. So this is the ECG that we have. I put there or there. And anybody on offer of training physician can comment on that.
Please raise your hand and then comment, please.
All right, otherwise I'll go further. Because time is restraining a little bit. Okay, anyway, we see that definitely is a wide complex tachycardia here, okay? And look at that. If you look carefully here, you can see some notching here. You can see some here, notching, some here. So some AV dissociation going on, okay? So that's one of the things you need to carefully look at that if any wide complex tachycardia. Look at that, how the morphology look like in V1 lead. It is lead bundle morphology, right? And look at that 2-3 AVF. What's the axis of that? It's a downward axis, like we call inferior axis, from top to bottom, okay? So it's a lead bundle morphology. So it's most likely coming on the right side, maybe, okay? And so an inferior axis, so it's going down. So it's maybe from the RVOT area, in that area, this VT. It's a VT, and we see some capture beat, and the PVCs look alike, okay? So it is a VT, and question right now is RVOT or VT or not, okay? So that's the concern. And when you look at that, let's see if anything. Okay, so how, what we did, so basically I think the ER physician initially started amiodarone. She converted, went back again, okay? And they called us, the cardiology got involved. And that time she was feeling dizzy, but she's still talking and she feels it, but she was not unconscious. And her blood work like CBC, K, MAG, TSH, all are in the normal range, okay? And what happened, then they put an amiodarone again, but then she went back again. Then we had to do a little bit sedation and shock her. She went back to sinus, then within a few minutes went back again. So she's going in and out, in and out. Then finally we put a lidocaine and bolus, and then it kind of stabilized and stayed in sinus rhythm, okay? We got an echocardiogram. This borderline LV function, 45 to 50%, slightly hypokinetic base to mid inferior septum, okay? So with that situation, recurrent VT and all these things, we decided to first, you need to look for, make sure that patient doesn't have any coronary artery disease, and looked at the coronaries, they're okay. The question right now, and let's sit here and discuss these patients, because the reason I put this ECG, because it looks like RVOT ventricular tachycardia, okay? This, in one sense, you can tell them this in RVOT VT. Sorry, I'm just talking about the EP more here, because we have our Dr. Rafiq Ahmed and Dr. Atharva is also here. You can comment on that anytime. But in the RVOT VT is most likely it's a common, right? Sorry, it's on the common form, benign form we think about commonly. And 90% of the time is probably on the RVOT area and or 10% LVOT area. And the features like right bundle, left bundle morphology and inferior axis, okay? But the question right now, whether you could let the patient go just with beta blocker, how you're going to treat the patient, okay? The cath is normal. or you leave it there, further workup, or you want to go proceed with further investigation. That's a discussion I'd like to put it on. Okay.
What did you do?
We just did the cath first, okay, and the cath is okay, okay, and then but the question right now, definitely look at that 45-50%. There's some hypokinesis based to mid infrareceptor, and the patient's happening these symptoms again and again, okay, and she's fairly young, 42. All right. What we did, I'll discuss, but any other thoughts that whether to let him go on beta blocker? Okay, let's see. What do we let's put this question. Let's put this question here and let's vote. Let's vote. Okay. Let's vote on that. Review, can you put that on the question?
Okay, okay.
All right, fairly spread. Okay. Any comment? Otherwise, I could go further what you did. Okay. All right.
There, no, before Ajit,
yeah,
the question would be, what is the problem with this patient? One issue is we look at mortality. Is the patient going to drop dead? That's one issue. Second issue is the symptom. Did she have syncope or pre-syncope?
She did not pass out, but she feels really fainty feeling near syncope.
Okay. Second issue is that if we go back to the ECG, please. Where is it coming from? So this is VT because it becomes white QRS, and especially if you look at the rhythm strip in lead 2, you can see the P waves interspersed. After the first white QRS, there is a possible P wave. And then after the 1, 2.
Just several places you could see.
After the 8, there is possible P. So the clear evidence. So, and the question is it outflow tract VT? No question about it. Is it right or left? And motion, any comment on that? Motion. Yeah. So you look at the transition.
Transition. I'm after EP fellow. Transition to
transition V3 V4 transition going on. No, actually a little bit delayed transition a little bit.
Yeah, so that supports more of a RVOT VT than anything else. So they keep that. So I'm just putting it out. I keep forgetting it. So please remember that when you see an ECG like this, you need to look at this. First, it is VT. Secondly, it's outflow tract VT because 2-3 AVF is positive. Third will be right or left. Look at the transition. You don't need to remember. Just remember the concept of transition. Look up the internet. Find out where the transition is. It will give you some idea. And even then, you will be wrong sometimes. And fine with that.
And then the risk. This is important because the risk of death is relatively speaking low. And the question is it the spectrum of RV dysplasia? And cardiac MR in the board exam, they will expect that you write that. But I like Rafiq Bhai's comment always that, you know, we acquire knowledge to use this for practical purposes, given the resources and all that. So is it necessary to do the cardiac MRI? By all means, to know. But the question is, if you have limited resources, what will be the best thing to do next?
Yes, no question. Okay.
Yeah,
And then
But I definitely will fail someone if they put in ICD. I'm going to fail that person.
yes. So that's what I was coming to. The ICD will be the most aggressive form of treatment, and this probably can be dealt with much less aggressively unless cardiac MRI shows ARVD. Okay, go ahead.
That's important. The reason is I like this discussion because as Dr. Rafiq Ahmed and Dr. Hassan mentioned that RVOT is fairly benign and they respond pretty well just beta blocker therapy and just observation and beta blocker therapy. And you know that RVOT VT's mechanism is we call delayed after depolarization. That's at the fourth phase of the action potential because of oscillation of the baseline membrane potential. If it goes threshold goes higher because of the calcium load that can happen from exercise, sympathetic activity, and rarely we see that digoxin toxicity or something like that. Then we call DAD, delayed after depolarization. That causes this mechanism of VT, and they're fairly common. But the question right now, one thing that bothered us that on this patient, there's LV function a little bit down, 45–50%. It's not terribly down, but mildly down. And there's hypokinesis based to mid inferior septum. That actually, in our institution, when you have fellows, they are all eager to do different kind of procedure and different kind of testing. We decide to go ahead to do the MRI. Okay, a cardiac MRI, and let's see. And let me quickly go over that. This is the first pass, okay, the 4-chamber view. And you know that we do the delayed phase after 15 minutes later, 15–20 minutes later. And we see that here, like in the right ventricular side, mid to apical septum area on the right ventricular side, so delayed gadolinium enhancement. And also in the 3-chamber view, we see that mid to apical delayed gadolinium enhancement. That bothered us, okay? And that fits the criteria that the VT is coming from here somewhere that I'm going to show later on. There's not probably benign VT, something else going on. And then we're bombarding our thoughts, and the fellow is always aggressive, okay? And we look at the other view, the short axis view. In the short axis view, this is the LV, this is the RV. When we see the inferior septal area, there's some delayed gadolinium enhancement, okay? This is a RV lateral wall. This is the RV OT, right ventricular outflow tract. And from here up to here, we see delayed gadolinium enhancement. And that might be the focus that we see RV OT VT that we saw on the surface ECG, okay? And that bothered most because we see multiple areas delayed gadolinium enhancement. Then the fellow wanted to do, and I agree with him, do FDG SPECT when the patient has sarcoid. Okay, that's another concern we had. Okay, I'm just quickly go through that. It's a little bit late, and we did FDG SPECT, and we see that this is the transaction view. What we see that the RV, LV, and we see that mid to apical septum, significant, activity there, okay? And actually what we combined that, this is the FDG PET CT, and we also did on this patient technetium, SPECT CT. We see the SPECT CT will see ischemia or, abnormal problem there, or any defect there. We see the defect in the septal area, okay? Mid to apical septal area defect. And here is the FDG PET CT, we see the activity, metabolic activity, very bright activity there. There's several places, okay? And actually our radiologist gave us more information, multiple nodules, multiple areas in the liver and spleen, high activity there, okay? And finally, they did a biopsy, liver biopsy on the nodule, okay? And we see the granuloma there, okay? And we see a lot of lymphocytes tissue around the nodule. Sorry?
Non-caseating granuloma.
Yes. So we confirmed that, okay? And then what we did, initially we decided, and with a rheumatologist and doc got involved, and we did a prednisone, metoprolol. And after that decision, then they decided to put the BIVs ICD. Definitely not in the beginning. We didn't even think about that. Initially, we were thinking there's just benign, right, RVOT, VT or not, okay? But because LV dysfunction kind of bothered us, inferior hyperkinesis, the septal inferior hyperkinesis bothered us. That kind of led to this discussion, and we went further. Initially, we did a prednisone and metoprolol and IVCD. And then we followed these patients, and he's still having some non-sustained VT. They tried temporarily with the methotrexate. And then a month later, she came back again with a very rapid heart rate. And she felt something machine sounding, but she didn't feel anything. But she looks like the interrogation, she had anti-tachycardia pacing that aborted that VT, okay? And then she was admitted again, get IV solumedrol, and then they started on mexiletine for the VT suppression, and the infliximab, that's Remicade here, a brand name, infliximab for sarcoidosis. And I'm going to go quickly because it's a little bit late.
Ajit, can you go
Yes.
back, please?
Which one? Okay.
Next, last slide before that. Patient got a BIV ICD, right?
Oh, yes. Yeah.
Is it the same? Is this the same EP doctor?
No, it's different.
Why did they put a BIV? How did they justify a BIV ICD in this patient?
Because my understanding is that these type of patients with multiple areas of sarcoid involvement, they probably will have conduction problem. No.
Ajit, I can die after 5 years or tomorrow, 3 days later.
Okay.
But patient at the time of ICD, BIV ICD implant, there is no IVCD. I'm just perplexed by this BIV ICDs business in that institution.
Okay.
It is BIV ICD or dual chamber ICD?
No, a dual chamber ICD you can make sense because you can say, well, because you want to.
Let me tell you. Let me tell you. I'm just taking it back. I'm sorry. I miswrote it. It's a dual chamber ICD. I'm taking back. It's my mistake. I'm sorry. It's my mistake. I typed it wrong. It's a dual chamber ICD. I didn't remember that. Okay. It's a dual chamber ICD. I'm sorry. Okay. But it's different EP. Okay. So that's correct. That's a good observation. It's my mistake typing it. It's a dual chamber ICD. Okay. And then let's look at that. We did the test because our fellow is really eager to follow these patients. And we see after Remicade, that's infliximab, we see that this FDG area went down significantly. And the SPECT also shows better. And she has much less recurrence of non-sustained VT right now on the monitor, okay? We're still following this patient.
So,
okay,
a couple of things, Rafiq bhai or Atar bhai or Mohsin, apnara ekটু explain করেন সবার জন্য what is the difference between dual chamber ICD and BIV ICD? Because
yes.
We need to clarify this first, and then I will make a comment.
Mohsin.
BIV ICD indicates the biventricular pacemaker plus ICD. Just it is this CRT-D, and dual chamber ICD means this is ICD one lead in the RV and one in the RA. This is dual chamber ICD.
So basically, in BIV you have a synchronizing lead. So there will be a CS lead in dual chamber. Yeah. Okay. So I hope that every participant is understanding that that what it means. Apnar case very interesting because the VT is RVOT VT type.
Yes, that's the point I wanted to make. Okay.
Yeah, but the echo finding is very not consistent with that, with the spectrum of RV dysplasia or RVOT, because it is the location of the hypokinesis is different. Because usually the RV dysplasia is a fibrofatty tissue in the RV free valve, not typically affecting the septum. And then in the cardiac MR or in the RV size little generous, and you do the ICD. So in the board exam purpose, it is always that without evaluation, don't jump on ICD placement, because you try to see whether if somebody tries to do ablation, I would be okay for that in the beginning. But even after ablation, Rafiq Bhai may comment, it would have still persisted in this case. But in the RVOT tachycardia, it's a curable disease if it is purely RVOT tachycardia. But here there is a structural heart. So when there is a smell for a structural heart, we are obligated to go after that. And your team very nicely went after that and found something different. You know, the septum typically in sarcoid, but also I don't know whether there is any clue. Is this patient an African American and a chest X-ray with pulmonary nodule or lymph node? That gives a clue.
Let me tell you, we figured out everything she had later on. Okay.
Yeah.
Ajit Bhai, can I interject?
Yes.
She's African American, right?
Yes, she is.
Yes.
Recently, in one forum in discussion, our Indian colleagues were saying they have treated a lot of the sarcoidosis induced ventricular tachycardias and arrhythmias, and instead of doing the implanting an ICD, what they resort to, they started giving steroid and everything, and later on they followed up these patients, and most of them patients later on do not need any ICDs.
That's a very interesting comment. That's a very interesting comment. The reason is
I'm not sure about any study whatsoever, but that was a personal observation, and they are actually doing the study regarding that.
Wadud,
Sir,
actually, the acute inflammatory phase, you are supposed to treat these patients. And a lot of these patients, this VT may, let's say somebody comes with non-sustained VT, and you find that sarcoid, this is the acute phase, and there is the acute inflammatory response. And then you are supposed to treat them and calm them down. And Ajit, one of the things I wanted to comment before Ajit,
we do live vest and treat the active phase, buy time, then reevaluate.
Absolutely, Hafiz, totally agree. But one of the things that if you looked at that ECG, the transition was between V4 and V5. That is a little too far out for outflow tract VT, even though it looked like outflow VT. Because most of the outflow VT, if it is left-sided, they will transition very early on. Even the RVOT VT should transition by V3, but there is no R wave. So that was one of the pointers against, against that. So this is a very, Ajit comes up with all these very, very interesting cases. So thank you. This is a good case. Go ahead.
Now, these are live cases. So we had discussion in our team. So I just pull up a few cases for you guys. Okay.
Thank you, Ajit Bhai. Atar Bhai, your comment, please.
Thank you, Dr. Rajesh Bhai, for your brilliant and excellent presentation, elaborate presentation. I think that is from starting to end of the all the cases with some that is all the possible test. That is very interesting to us as because actually we cannot deal the cases. We had got such type of cases, but we cannot do all these kinds of the tests in all those cases. So these are the good points we have learned today. An excellent discussion. And I like to congratulate Dr. Rafiq sir, Aziz Bhai for participating in this discussion, Sudhri, Abdul Wadud Sudhri also. And I also like to thank Dr. Ozoy from Sylhet and Dr. Bishal Sreshto from Nepal for participating in comments in chat box. Nice comments. They have put their comments. And I can see Urun Maski, Dr. Mohsin Hussain for participating in their discussion. Excellent session today. Urun Maski. Can you see us, Urun Maski? Urun Maski, do you have any comments, Urun Maski, for today's session? Excellent, brilliant presentation by Dr. Aziz Bhai. Urun Maski.
Yeah, these sort of cases we would be looking forward. Actually, case-based discussion is very good. At least you learn a lot of things from clinical and practical things. These are very useful cases. Thank you, Dr. Aziz, for nice presentations.
I just wanted to congratulate Dr. Vishal Shrestha,
Right.
because I really admire that we don't need to jump. When there is an issue, it is better to give a differential. And I really liked your differential in the chat box. And that should be the approach. That
Dr. Ozoy from Sylhet also. We have got Dr. Ozoy from Sylhet. He has got good experience in cardiac MRI and he have give some good comments in the chat box. Dr. Ozoy, congratulations. And Dr. Abu Naim Mahmood, thank you very much for your coming forward. We like to welcome you in the next session, Dr. Abu Naim. This session is for you actually, Dr. Abu Naim.
So let me finish this 30 seconds. While we are doing this, we had a cardiac arrest.
Oh my goodness.
So I'll probably show you this, but let me tell you this story and then maybe a comment. So 82-year-old cath lab, I'm here. I said, okay, go and figure it out. I'm here. So, and then fellow says, this is a real STEMI, 82-year-old, had a hip surgery 6 months ago, and now coming with this chest X-ray, little widened mediastinum, and the patient passed out in the waiting room, and then had CPR, and now the blood pressure 50, and the heart rate like 40, and they are asking me, are you going to take this patient to the cath lab? And the patient is intubated, and the ER doc is looking at me. What should I do? Any comment?
Chaudhary?
So you know, I said, what guys, what was the rhythm? The rhythm was asystole. When the rhythm was asystole, then if it is a VF arrest, I don't know if Rafiq is here. When there is asystole, then I usually say, okay, continue drinking coffee. I don't get excited. I said, and then I tell them to do blood gas, and then do a bedside echo, CPR, continue. And I said, this is not, the problem is that after a couple of AP, the EKG shows ST elevation and right bundle in the inferior lead. And I said, I'm not. And then when you do VP, then shocked, then giving the amio, lido, etc. And I still did not budge. And then the patient did not survive. We did the bedside echo, no pericardial effusion, aortic root is okay. So what is the likely cause? We don't know. So, but I did not accept that this is a MI. And my question to you is that, will you agree with that or will you be against me? It was I told them that I need a pulse and blood pressure for 5 minutes before I take to the cath lab. I don't take a dead patient in the cath lab. 5 minutes, a pulse, they could not give me, unfortunately. So this is my thing to the fellows and residents, that MI with bradycardia, so MI with asystole and pulseless electrical activity is rare. It can happen though. It can happen, but it's rare. And then in this case, most likely is a pulmonary embolism. The RV looked dilated, moderately dilated at least. So that's what we are suspecting, but that's why I missed some of your presentation, Aziz Bhai.
No, it's okay. Thanks for a lot of good comments. God bless you. We need to treat the patient.
So thanks everybody. We can conclude the session today.
Thank you.
Thank you again, Dr. Aziz Bhai.
Thank you.
This is a very interesting discussion. Thank you.
No, I like the discussion. That's, I put forward, because I have a lot of things to learn myself. Okay.
Actually, we have been using off-label evaporative for many problems, particularly in post-operative patients. Due to pain, they have sinus tachycardia, and that in a borderline case of ischemic heart disease, that aggravates the situation. And if you just reduce the heart rate, that gives comfort to the patient, and that patient cools down and the hemodynamically become very stable. It's a very useful drug.
Yeah, I've been using that. I also
Okay.
good luck with that.
Wadud,
Sir,
I don't think it's an off-label use because they approved the drug in a wrong way.
yeah,
This patient, we are having major problem because we have a lot of young patients with blood pressure of 105, 106 systolic,
right.
inappropriate sinus tachycardia, EF normal, and I cannot prescribe this medicine. So in the study, they excluded the patients who really need this medicine. So the process of approval is wrong. They must include this sinus tachycardia, just
Sir,
sinus tachycardia.
Sir, to tell you the truth, I have many patients who have this persistent inappropriate sinus tachycardia, and they are so grateful to me because of this drug. I've been using for last 3 years in many patients, and the
That's
patients, they know when to increase the dose and reverse the dose. I always tell them, just use the dose that you feel comfortable with. And they feel very comfortable using the 10 milligram or 15 milligram a day. They just change their dose as per their need. Thank you.
That's
everyone.
good. And I've been using that definitely for inappropriate sinus tachycardia. Absolutely. That's good drug. Thank you very much. Good
Thanks,
night,
Ajit.
everybody.
Okay.
Thank you.
Thank you.
Bye. Thank you.
Assalamualaikum, sir. Thank you.
Walaikum assalam.
भाई खुदा हाफिज मोहसिन खुदा हाफिज भाई